to move forward the next session, which is focusing on optimizing patient for ABO incompatible liver transplant. I'd call up on the stage the chairpersons, Dr. Kaushal Madan, Director and Head of Gastroenterology Department, Max Hospital, Saket; Dr. Mukul Rastogi, and Dr. Mukul Rastogi, Senior Hepatologist and Gastroenterologist at Fortis Hospital, New Delhi; and Dr. Rakhi Maiwal, Assistant Professor of Hepatology at Institute of Liver and Biliary Sciences, New Delhi. Sorry, ma'am. Dr. Rakhi Maiwal, Additional Professor of Hepatology. And for the first talk of the session, which is Principles and Techniques of Plasmapheresis and Immunoadsorption, I would call upon a stage Dr. Sangeeta Pathak, Head of Department of Transfusion Medicine and Blood Bank at Max Hospital, Saket.
A very good morning to all of you. And at the outset, I'll thank the organizers for having me here. And I'll be talking upon the principles and techniques of plasmapheresis and immunoadsorption. So to start with, apheresis, we all know, means taking away from. So something taking out from the blood, which is offending agent, removing it, and then re-infusing the suitable substance. So the process is whole blood is withdrawn from a person's circulation, a component such as plasma is separated and retained, and the remainder is returned to the patient, usually with some replacement fluid. So there are various types of pheresis, the donor pheresis and the therapeutic pheresis. Donor, which we do usually for the platelets in routine terms, that if I tell you, means for the collection of platelets, and the therapeutics, that is for the removal of disease or pathological components from a patient. And the various modalities of the pheresis are there, in which manual is abandoned, usually it is not done, but the automated pheresis is mostly done nowadays, and it is done with a specialized device which controls the rate of withdrawal, anticoagulation, separation, replacement fluids, and the rate of blood return. And as I said, the goal is to remove the pathological elements from the blood and eliminate the offending agents of various types. Can be the plasma proteins, that is antibody in the myasthenia gravis, red cells in sickle cell anemia, leukocytes, as in hyperleukocytosis in acute leukemia, and platelets in thrombocytosis. Then, if I talk about what types of removals are there, so cytopheresis, in which cells are removed, and the plasmapheresis, where which is concerning at this moment here is the removal of plasma. And the various other modalities are like the selective extraction, adsorption, red blood cell exchanges, and the cellular depletions, that is removal of abnormal red cells or white cells or the platelets. So these are the various types of the modalities which are present, the conventional one and the less conventional methods. So if I talk about the conventional, they are the plasmapheresis and the cytopheresis. I've already spoken that. Then in plasmapheresis, if there is a replacement with, means the replacement fluids can be various types, that is FFP and albumin. And in cytopheresis, there are various types of cytopheresis, the erythrocytosis, thrombocytoapheresis, and leukopheresis. The less conventional methods that are being used are the immunoadsorption, filtration, selective removal, LDL pheresis, and the photopheresis, and the collection of blood stem cells and the WBC reductions. Then the topic that has been actually designated to me is the removal of the therapeutic plasma exchange, that is removal of plasma components from a patient. Is it this? Yes. Okay. From a patient using apheresis technology performed for the purpose of removing disease plasma or the responsible pathogenic substance present in the plasma. Okay, then based on these following assumptions, a disease state is related to the presence of a substance found in the circulating body. The pathologic substance in the patient's body can be removed efficiently enough to permit resolution of the illness, or at least to significantly decrease the disease morbidity, and the patient may benefit from both the removal and the replacement of the fluid that is given. Then that's the fundamental principle of TP. I've already spoken this, that the blood substance, there's a disease state because of the blood substance, and removing will cause this. That's the basic circuit of TPE, in which the patient is here through a blood pump, the substance is removed. If specialized columns are used, then it's there, and a substitute is then given back to the patient after removing the offending agent. Then the efficacy of the TPE, that is we all know that it's not curative, but it's an adjunct therapy, and it will relieve which relieves the symptoms and control of pathogenic process. And this has also been established, of course, by the American Society for Apheresis. The efficacy of the treatment will be related to the volume of the blood process, the rate of resynthesis of the offending factor, and the ability of the end organ to repair itself of the disease process. Now, this I just bought a slide just to say that even in the earlier times, decades back, when these specialized processes were not in place, at that time also it was thought that in blood there is some offending agent, and letting out of blood would cure something. Now we have definitely specialized procedures to come out with that thought that was there years back. So I already have shown a part of it. There's a vascular access, there's a blood pump, there's an anticoagulant which is being used. Then the processing is there. Processing can be with the help of either a centrifuge or a filter. The replacement fluid is then given. The plasma, the offending plasma, is collected in a wastage part, and then it is given back. And there are typically two methods of doing that, a filtration and a centrifuge. The filtration method depends on the pore size, and the centrifugation depends on the cell size and the density. So the centrifugation method would be of two types, the intermittent flow and the continuous flow. So the continuous flow have a rotating channel designed so that the whole blood is introduced at one site, and the blood elements subsequently separated by density as blood flows through the channel. And the component, which is whatever component has to be removed in this context that we are talking, is the plasma, is diverted into a collecting bag, while the remaining blood components are mixed with replacement fluid and returned to the patient. Most commonly, this is the most commonly used method, and intermittent flows are usually they are not, nowadays we don't use it, except at times we do have equipment with us in which intermittent flow is also there, but usually it saves the continuous flow saves time and is a faster technique, so we always use a continuous flow method. And in this, a specified volume of whole blood is withdrawn into a bowl, then the withdrawal is stopped. That's what the time is more in this. In the intermittent, the extracorporeal blood is then processed. The process is repeated for a certain number of cycles, and most commonly used for photopheresis. This is the circuit that I was talking about for the centrifugal TPE, in which there is a centrifuge here, and after withdrawal the blood is processed in this centrifuge. After then, the replacement fluid is returned back to the patient after removing that. And the filtration devices which are there are mostly used with the dialysis. People do use dialysis equipments also, and the filtration devices are with that. So they also operate by continuous flow, and blood or plasma is passed through a microporous filter that allows plasma to pass and retain blood cells. The separated plasma is diverted into a waste bag, and this is only restricted to the use of plasma, not for cytopheresis. That's the circuit that means for membrane filtration. It's the membrane plasma separation filter which is here, as compared to the centrifuge which was there in the other system. Then there are various type of equipments that are being used for plasmapheresis, and in our setting we are using these two I'm showing. There is a third equipment also that we use at times, and centrifugal TP is performed with the help of specially designed apheresis equipments, and the best option is through continuous flow. I already said that blood is withdrawn and then continuously the blood comes out and continuously it is being processed and used. So that's the difference between a centrifugal TPE and membrane TPE, and that's a paper that I just bought here to support this, that a centrifugal TPE processes the plasma extraction is approximately 80% as compared to the volume that's being used here, 3 into blood volume as compared to 1.5 into the blood volume. The extraction is 30%, while the extraction with the centrifugal TP is about 80%. That's the paper which says, and there are multiple papers which support this thought. Then the integration categories are defined by the American Society for Apheresis, and in conjunction with the American Association of Blood Banks, they have put up guidelines on the use of therapeutic apheresis in clinical practices, and this was the guideline that was framed, and I'll just show you one by one that it is divided into 4 categories, and these 4 categories are category 1, that is the disorder for which apheresis is accepted as the first line of therapy, either as a primary standalone treatment or in conjunction with other modes of treatment. That's category 1. Then category 2, in which it is accepted as second line of therapy, either as a standalone therapy or in conjunction with other modes of treatment. Then category 3, optimum role of apheresis therapy is not established. It's still not established, still it is being used. Decision making should be individualized. And the 4th category which is there, it says disorders in which published evidence demonstrates or suggests apheresis to be ineffective and even harmful, and the approval from your local ethical committees is required if apheresis treatment is undertaken in these circumstances. So these are the broad categories that I bought from these AFSA guidelines only. And category 1, that is the one which is the first line of treatment and can also be used as standalone. And these are categories TTP. We all know TTP is one of the best treatments that plasmapheresis offers. And ABO incompatible liver kidney transplants, cryoglobulinemia, good pastures, acute inflammatory, homozygous hypocholesterolemia, hyperviscosity, myasthenia gravis, PTP, and focal segmental glomerular sclerosis. Similarly, category 2 has all these diseases which can be treated well with it. 3 and 4, again, they're not very, the 4th one is actually not established at all. So it depends on the prerogative of the treating person if they want to use it. Now, how much of plasma exchange should be done actually with the patient? So the exchange is usually in terms of a plasma volume. And whenever we talk of plasma volumes, we usually talk about 1, 1.5, 3, like that we talk about. So how are they calculated? How is the plasma volume calculated? With the help of the patient parameters, a total blood volume is calculated in male 70 into weight, while female 65 into weight. And the total blood volume into 1 minus hematocrit gives the plasma volume. Okay, that's the basic formula that's being used, which is applied usually for the calculations of the plasma volumes. And the plasma volumes are calculated by the equipment itself, because they are automated equipments and they calculate the amount of plasma to be processed. So in one of the equipment that we use, this is it's a Nadler's equation that particular equipment uses. It differs in all, but the plasma volume is calculated similarly in all the equipments. Then effectiveness of TPE. It's always a question that the antibody status are not coming down. It always is a problem. So the effectiveness depends on the concentration of the offending agent in the blood, the equilibrium between the blood and the extravascular volume of distribution, and it is most efficient at the beginning of the procedure and least efficient at the end. So the number of, the more volumes that are being processed, it does not give a fruitful result. And in principle, the exchange of a single blood volume will eliminate approximately 2/3 of a substance if it does not move from the extravascular sites to the intravascular space. So that's the principle that is being applied for doing the plasmapheresis, the reductions, Then, with the continued production of the substance, which is the offending agent that I'm trying to remove from the plasma, from the body, if there is a continued production of the substance or mobilization from tissues into the intravascular space, it will result in less apparent reduction despite an equal or even greater total amount removed. Okay, so that's the catch also, that even if we keep on increasing the volumes, the reductions keep on being they get stagnant on a particular number. Plasmapheresis is usually limited to, as I said, the best is 1 to 1.5 volumes, or it's this approximately 40 to 60 ml plasma exchanged per kg of the body weight in patients with a normal hematocrit and an average body size. Okay. Now again, that is also one, that's the relationship of removal of plasma constituents to the volume of plasmapheresis. So on the y-axis, there is fraction of the original plasma remaining, and on the x-axis is the volume of plasma removed during TPE expressed as a ratio to patient circulating plasma volume. So the best gains are, the ones that we use mostly is 1 and 1.5. That is, 1 is 63% plasma removed and 1.5 78% of the plasma removed. If you see here, 3 is 95%. 95% of the plasma removed, but 95% of the plasma removing brings a lot of other limitations along with it. Okay, so we usually stick to either 1 or 1.5. We do go to higher levels at times, but usually the best options are 1 and 1.5. Then, although larger volume exchange causes greater initial diminution of the pathologic substance, overall, again I'm saying that it is less efficient and requires more time. One cycle of, a session of plasmapheresis usually takes somewhere around 2.5 to 3 hours. And if we keep on increasing the plasma volumes, definitely the times increase. Larger volume exchange can increase the risk of the coagulopathy, citrate toxicity, and the electrolyte imbalance. All present in the plasma, definitely, so it affects. Okay, then the frequency of TP procedures at our place, usually clinicians decide on the frequencies, and we are the facilitators for that. So we rely on them, and they are the ones who call us for the repeat procedures also, whether it's 72 hours, whether it's 48 hours. So it's the clinical decisions that come, and how we are directed, we do those plasmapheresis. So the frequency of TP can be disease specific, relates to the type of antibody present and the rate at which it equilibrates, that is, it redistributes or comes back, rebounds. Again, as I said, it's the physician decisions that come, and the treatment plan and goal of therapy is also physician dependent. And in our cases, we do all the plasmapheresis in an ICU. So cover of the clinical team is always there with us when we are attempting a plasmapheresis, because as blood bank and as blood centers, we usually are not tuned with the clinical side, and therefore we need a cover of the clinical team, which is always there. We've been doing it in an ICU, and we've had excellent cover from the liver team. It's always there. We've been doing a lot of plasmapheresis for our liver team. An excellent support, I should say. It's always there. I need not even put it up that I need some this. It's always there. Thank you so much for that. Then the basic things that are required are the informed consent, consent check. The veins are very important. So veins means we do always take a central line, and the patient preparation is always there, which again, I need not even bother. It's always whenever we go and shift our equipments, the patient is already ready for us. Then you all know it's a non-specific therapy. Besides removing the disease substances, it also removes the normal plasma components, and which are means required for hemostasis, like the immunoglobulins, the other things like cholesterol, albumin, fibrinogen, urea, creatinine, electrolytes, and the plasma-bound drugs are also removed. So we have to take a decision accordingly that plasmapheresis needs to be done in how many intervals, and how often means it is required, because of all these limitations as well. Now, there are certain alterations in the blood constituents after a plasma exchange, and these are in terms of percentages, if I talk, the clotting factors, they decrease from baseline from 25 to 50%, though the recovery within 48 hours is 80 to 100%. Fibrinogen to 63%, recovery 65%, immunoglobulin 63%, approximately 45%, paraproteins, liver enzymes, bilirubin, C3 components, and the platelets. The reductions in platelets are dependent on the type of equipment you're using, and they are sometimes more with certain equipments, and so you have to get it controlled and not use those equipments which do a considerable decrease with the platelets. And that's the reference that I had bought it. Then about the proteins, in the intravascular component, IgM is about 76%, IgG is 45%, albumin is 40%, and the light chain scale and alpha light chains are 15%. So the IgM is removed more efficiently than IgG. Both re-equilibrates within 24 to 48 hours to effectively deplete both IgG, total IgG by 85%. It requires 5 exchanges into 2 days. Only 2 to 3 exchanges are required for IgM. And effect of plasma exchange is temporary. Of course, we all know that it is not a curative treatment unless the underlying and the baseline cause is removed. Plasmapheresis cannot play a role on its own. Then important that what are the replacement fluids that are used, and it depends upon the type of procedure and the patient coagulation status. Crystalloids are used, and the most important, besides the crystalloids, we use a lot of 5% albumin. Albumin has a lot of advantages. It has a long shelf life, minimal risk of infectious disease transmission, which with FFP is always there. Though it is a tested component, but still it is there. High cost is a disadvantage for the use of albumin. And other disadvantages is the coagulation factors, ADAMTAS 13, which is important with TTP, not in cases. So it would be important for TTP cases.
Excuse me, Dr. Sankita. Excuse me. Here, over here, Dr. Meenu. Hello. Yeah. I was just saying that time is a little short.
How much
if you
time?
can,
2 minutes.
You
I'll
can
finish
see
it
it.
off. I'll finish it off. So, albumin lacks the coagulation factors, immunoglobulins. During intensive plasma with the albumin replacement, depletion of other plasma proteins can occur. So, in the first part, we use an albumin, and then replacement mein hamesha we always give a FFP also. Allergic reactions to albumin are rare. So, I'll now lead to rush. FFP सबसे ज़्यादा देते हैं हम लोग, and it is being used, and a very, it is a user friendly also, and pocket friendly also, as when we look at the patient also, that it is not that expensive. Then it carries all these risks. अब मैं जल्दी जल्दी पढ़ा रही हूँ और इम्यूनो एब्जॉर्प्शन शायद रह जाएगा. So things to remember, I'm leaving. These are the complications of plasmapheresis. बहुत सारे complications होते हैं. In my setting, what the complications which we have seen usually are is the hypotension, and only 4% of the entire plasmapheresis that we do, 4% of the patients do experience certain complications. One of them is the highest, is what we have seen in our setting, is the hypotension. Might be because of the plasma being exposed to a lot of plastic material, which the kinine system is activated. Bradykinin release होता है, bradykinin से hypertension होता है. अब मैं जल्दी जल्दी बोल रही हूँ. I'm not doing all that. Selective extraction, the adsorption techniques are there. There are various adsorption techniques. बहुत सारी हैं. Double cascade immunopheresis, LDL, fibrinogen, toxin apheresis. I remember doing a toxin apheresis years back when I joined this hospital, and we did save the patient. Then double filtration होता है, जिसमें एक filter use होता है extra. मतलब दो चीज़ें use हो रही हैं. Okay. Then this is the circuit cascade. I'm not going now. This is Dr. Asim Tiwari sitting here. His paper is this, which was for the cascade pheresis. Immunoadsorption, I won't go again in details. Indications, सबसे ज़्यादा indication है for ABO organ incompatible transplant. Then immunoadsorption के types हैं non-selective, semi-selective, highly selective. Highly selective में we do use a glycosorb ABO column. This is the setup. That's the column that's being used. That's the column. Extra column that's being used. Okay. ये नेफ्रो वालों के लिए ज़्यादा important है. I'm just skipping it. LDL we did for one of our patients. My chair, I cannot afford to कि मेरे chairs गुस्सा हो. So then indicators for this. And to summarize, I'll say the membrane filtration से better है centrifugation methods. So I have no questions with my liver team, but just to put it overall, that centrifugal plasmapheresis is better than a membrane one. Thank you so much, and thank you for giving me that extra time as well.
Thank you, Dr. Patak, for such an exhaustive talk. So I think time constraints, we will not take a question. We should move to the another topic.
We have two experts there, Asim and Dr. Minu, who work in this field. So maybe if we don't allow them to have, it will be unfair. They are really experts in this field. Yeah. So a few words from them.
Yes, just a small comment. Yeah, it was an excellent talk. Thank you very much. The only thing is I disagree with using FFP. We need to really limit the use of FFP because many of the adverse events happening in the patient are happening because of plasma. So it has to be albumin which has to be preferred over plasma unless you have the coagulation which is deranged. And we need to monitor the coagulation profile. Alternate procedure, we can do the PT, APTT and INR to decide upon
it's
the coagulation.
The same we do. Don't worry. We don't.
So I just wanted to
advent use of FFP is not there.
Correct.
For renal, it's very easy. You go for albumin, it's easier. In the liver disease patients, you have to take into consideration the coagulation status.
Correct. Dr. Rakhi, also we can have your comment also.
I think so. I have nothing more to add. Took everything was discussed in your talk, and I totally agree. Centrifugation is a better technique, but in a sicker patient, and that's what we're planning to do a study at ILBH to compare the two techniques in the sicker set of patients where they are already on CRRT, already having
Exactly.
renal failures,
Then-
anuric. So that set of patients maybe centrifugations too. They don't handle that procedure.
Hard
Yeah.
on them.
Yeah. So that is one area we can obviously work.
Over to Mukul.
Thank you so much, all. Thanks a lot.
Especially in ABO incompatible transplant, which blood group plasma do you use? Is there any
AB.
difference between
AB.
only
No thoughts on that. It's AB. Thank you so much for your patient listening. And I close off. Thanks a lot.
Either AB group or the donor group if you run out of AB.
Thank you
Point I would
very much,
also
ma'am.
like- I would also like to make that AB is not always available. Less than 10% of the 10% less than 10% of the population is AB. So the amount of AB plasma is limited. So going with Dr. Asim's centers with the donor group.
The one thing that I have in mind, which would we recommend? Cascade, double filtration, of standard plasma
The
freezes
gold standard
for.
would be the glucose the immunoadsorption columns.
Trouble with immunoadsorption is fairly expensive.
But you're not getting.
And I'll tell you why. One more thing. We do quite a lot of plasma exchange post transplant. So therefore, it really doesn't make sense to do both. We did do a lot of immunoadsorption at beginning. I think the problem is we will sometimes just do it for doubling of titers. We do plasma quite often. And although they can be reused, but it loses its efficacy after it's washed.
Absolutely. The efficacy does go down. Sir, the principle is that we need to understand that, as Dr. Pathak said, that normally when we do a conventional plasma exchange, we process around 1.5 volume. When we do a cascade or DFPP, depending on whether it's a centrifuge plus membrane or two membranes, we process around 3 volumes. And when we do immunoadsorption, we can process almost 5 volumes. So larger is the volume processed, greater is the decrement in the antibody that we are trying to do. Having said that, unfortunately, the one which is best is also the most expensive. So many a times the only the decision is based on the patient's affordability. So if the patient can afford, we'll do immunoadsorption. If the patient cannot afford, we will do a cascade. And if the patient really cannot afford, we'll do a conventional. Another thing which we have noticed in our experience is that sometimes even when immunoadsorption does not work, your conventional may work.
It works.
And vice versa. So sometimes, you have to understand that one is not working, we'll try with another. But eventually, I don't remember a patient where we have been not able to desensitize by using some combination of therapeutic procedures.
But what is the effectiveness of all these modalities? Plasmapheresis versus immunoadsorption versus DFPP. I think they are equally effective.
Sir, the most effective would be immunoadsorption because you are able to process a greater amount of volume. So you would get almost 3-4 log reduction in the antibody titer when you do immunoadsorption. You get around 1.5 log reduction when you do a cascade. And you get around 1 log reduction when you do a conventional. So the efficacy is absolutely different with all 3 procedures, and therefore the cost also goes up with the better procedures.
Another issue is when you coming to lower titers and there's a resistance to further decrease in titer. At that time, sometimes I've seen that therapeutic plasma exchange, simple exchange works better when you're stuck at a somewhere around 36, 64. Over there, sometimes the therapeutic plasma exchange works better.
I have a question. So, like in the pre-op, while we are desensitizing, which is better? Like, shall we directly go with immunoabsorption or plasmapheresis? Means, is there a concept that directly doing immunoabsorption can lead to saturation of the filters, and it is better to do plasmapheresis to bring down the titers and then go for absorption?
Nothing like that. It is plainly, if you can afford, immunoadsorption is the best. There's nothing like that. This would be better, and there would be a saturation. You see all the procedures, the graph is like this. So you have a higher efficacy during the initial part of the procedure, and the efficacy goes down. That is common to all 3 modalities. That does not change. So you would have very good decrement during the initial procedure, and then slowly it will be gradually going down. There will be around 10% of patients who would have some kind of rebound. So you would have a decrement. Your titer would go down from 64 to 16 today, but tomorrow when you measure, it's again 32, and then it goes down to 16, and then it gets stuck at 16. So those kind of challenges would happen in some patients because each patient would behave differently.
Sorry to interrupt. We may have to cut down the discussion here because we are time bound.
Tea break for that. It's a very important topic. Please don't go away. Yeah.
We will go forward for tea break, but before that, also there is one more interesting talk. So I'll please call upon stage Dr. Vinendra Pamecha for the topic of role of rituximab and IV immunoglobulin. He is professor and head of liver transplant and hepatobiliary surgery at ILBS New Delhi. Please, sir.
Hi, thanks a lot. Thanks, Dr. Sehgal, Dr. Gupta for having me here. So, I think what the topic, this is the most important game changer which has happened in the ABO incompatible liver transplant. So, I think this bit has already been touched, so I won't go through this, and this has also been taken care of in the previous talks as well. So just to go through the mechanism of rejection in ABO incompatible liver transplant. So it's about basically having an antibodies which leads to complement activation, inflammation, and then microvascular thrombosis. So these are the various desensitization modalities which are there, and it's about cessation of antibody production, which can be done by rituximab and IVIGI, or you can do a splenectomy or use immunosuppression in higher doses as well. And then removal of existing antibodies, which has already been discussed in the last talk, and then prevention of intrahepatic DIC by having portal vein infusion therapy or hepatic artery infusion. So coming to rituximab, the rituximab has been the most important game changer which has happened to ABO incompatible liver transplant. So this was the drug actually which was discovered for treatment of blood cancers, and it is a chimeric monoclonal human murine anti-CD antibody, and it depletes B cells. And the CD20 antigens are expressed on the pre and mature B cell, but not on long-living plasma cells persisting in the bone marrows. So what exactly it does is basically it depletes, because of combining with the CD20 antibodies, it actually depletes the complement-mediated cytotoxicity by macrophages and neutrophils, and then it decreases the apoptosis, and it also acts on the T cells as well, on Treg and helper cells 2, and decreases the activity of helper cell 1 as well. So overall what we see is there is a reduction in the complement activation, inflammation, and leading to decreased chances of having microthrombosis as well. So a single dose of ABO incompatible suppresses B cell activity for almost 6 months after liver transplant in peripheral blood. And most programs have adopted a dose of 375 milligrams per meter square derived, and this dose is actually not derived from the liver transplant data. It's mainly derived from the B cell lymphoma data actually. So that's something which has become debatable in how to use rituximab in terms of liver transplantation setting. So whether to use a low dose or high dose, will come to that as well. So what has happened after rituximab has been used, the things have changed, and the overall survival, the 5-year survival, which was around less than 50%, has gone up to 70%. And this has been consistent in most of the papers over the time which have been published. And so there is a decreased rate of AMR, there is decreased rate of ACR, although not significant, but still proportionately the rate of ACR decreases, although almost similar rates of bacterial infection, fungal infection, there is a decreased rate as well. And then CMV disease almost remains same after the CMV has been introduced in ABO incompatible protocols as well. So this is the meta-analysis which has been published. It's about 9 studies, more than 3,000, nearly 4,000 patients, with about more than 600 patients with ABO incompatible and 3,000 patients compared with ABO compatible transplants. There was no significant difference in 1, 3, and 5-year overall survival and graft survival. Moreover, the important thing is the recurrence rate after HCC have also remained same even when rituximab used, especially in live donor setting in terms of doing transplant for HCCs. However, the incidence of CMV infection, AMR, overall biliary complication and biliary stricture rate have not changed, and they remain same on a higher side with ABO incompatible live donor liver transplantation. So this is just the same data from the meta-analysis showing overall survival is similar to ABO compatible grafts, 1 year, 3 year, and 5 year survival as well. Okay, then when we come to HCC, because we see more and more patients with HCC coming for live donor liver transplantation, and that is always a case because we are living in an era where the number of donors who can donate to their loved ones are limited, and it is always temptation to do an ABO incompatible transplant. These are preserved patients as well. So the thing about is whether the recurrence rate will be higher in those group of patients. But when we look at the data, published data, although the numbers are not very big, 31, 39, 59, 165 there, that is the registry data, and the overall recurrence rate were similar. These are the recurrence rate and the overall, if you say the recurrence free survival, which was similar between the ABO compatible and incompatible at 1 year, 3 years, and then this is 1 year and at 5 years as well. So the determinants of recurrence again in this group of patient were the tumor biology rather than whether the rituximab was given or not. Okay, so it's again just fall downs to tumor biology in LDLT in terms of transplanting for HCC with ABO incompatible live donor liver transplantation. So what is the ideal dose of rituximab? And that's something which has remained debatable. And this is again an analysis of various dosing which have been done. And what it has been seen that there is, when you use higher dose, then the rate of AMR actually decreases, although the bacterial infection remains same. But again, the rate of viral and fungal sepsis is higher when you use regular doses of rituximab. So regular is 375 milligram per body square area. So then comes what are the side effects, because this drug does have a side effect profile, and infusion related side effects can happen within 24 hours, which can lead to allergic reactions and such as swellings of the lip, oral mucosa, tongue, throat, palpitation, flattering. And then it's always good to have a pre-medication done before giving rituximab. Overall incidence of adverse events are about 1 to 3%. There have been severe side effects reported as well, and in I don't think in liver transplant, but in other setting deaths have been reported after rituximab infusion as well. So it should always be done in a setting where resuscitation is available, and there should be a proper checklist before you give rituximab to any patient, and you should have resuscitation facilities available. So either you are giving it in an HDU setting where all the facilities are available in case you have allergic reactions. Then in the context of liver transplantation, it is very important actually to have all the cultures negative before you give rituximab. So you have to do the cultures, and they should be negative. X-ray should be okay, and they should have normal counts as well, because it is expected that they're going to have a fall in their counts. But rarely in liver transplant setting you will find they don't have pancytopenia. So you have to just go by a clinical judgment that who can be good enough to have it. But culture should be negative, because there is a high risk of in sepsis after rituximab infusion, especially urinary sepsis as well. So this is just the instruction, and I won't go into this, but it should be administered in an area where full resuscitation facilities and monitoring is available. Strict aseptic technique should be observed, and most reactions are noted during the first few minutes after the infusion, so you should be careful about that. And vital monitoring need to be done as well. So these are the adverse events which I have already talked about. I won't go into details, but this can happen, and there are good incidences of this, so you should be preventing it. Coming to IV immunoglobulins, IVIGI, and this basically the mechanism of action is apoptosis of B cell or plasma cell through the Fc receptor dependent pathways and inhibition of alloreactive T cells or complement mediated allograft injury. So the use is basically, Ashok has already gone into details of the role of IVIGI, but in terms of, in the context of liver transplantation, it's mainly used for rescue therapy in case of severe AMR, where you're finding it difficult, the titers are going up, and also along with that the biochemistry is, and you suspect that there is a severe AMR, then that's where the IVIGI has got a potential to actually rescue the graft, salvage the graft. Then in pre-sensitized recipient to treat the AMR, and if, and we do encounter a lot of situation where you have to do an ABO incompatible sort of emergency or semi-emergency situation, and there IVIGI can be very helpful actually if it is administered after the transplantation. So obviously you go with the titer and see, but if you didn't had enough time to give rituximab to, like, within, you're planning to do the transplant for an ALF where you already done a plasmapheresis. So we had situation where we done transplant in an ALF, plasmapheresis was done as a routine protocol anyhow, the titers were low, so we went in and did the transplant. So in those situations actually we gave the rituximab after reperfusion, and there actually there can be a role of giving IVIGI in those situations in order to buy the time and prevent AMR in those situations. Again, so we had instances where we done emergency transplant for ABO incompatible, and you can actually get away having a good result in those situations as well. So this are just the summary of salvage data on IVIGI being used, and most of the time there was good rescue in terms of combining with plasma therapy, plasmapheresis as well, and the AMR could be treated in those situations. So these are the adverse effect. We all know immunoglobulins can cause again allergic reaction and lots of other problems as well. So need to be aware of all those neurological, respiratory, cardiovascular, GI and renal upsets, and also the allergic reactions as well. So, but they are mainly used post-transplant only, not in the pre-transplant setting. So these are just the desensitization protocols which are currently being used. So you start with rituximab. The dose is variable, but most centers will give standard dose now rather than giving low dose. And then obviously you do the plasmapheresis days before the operation. Again, the timing of rituximab, previously it was about 3 weeks, but now centers feel like even 2 weeks is good enough to go in and do a transplant. And then you do the titers and see the titer, and depending on that you do the plasmapheresis, and then you do the transplant. And obviously you will need a higher than not required immunosuppression in the post-transplant period in this group of patient. Okay, so the take home is rituximab has been a game changer in ABO incompatible liver transplant. Overall survivals are similar now with the availability of rituximab. Ideal dose is still debatable because we see a lot of sick patient and coming through with for ABO incompatible. So you have to go by case in those situations. Even in the presence of emergency, semi-emergency, you should be giving it. You should not be holding it back, thinking that the titers are low. You've done the plasmapheresis in ALF, titers are very low, you can go ahead and just do transplant, but you should still give them rituximab. And IVIGI can be good for rescue therapy for AMR when you have a short time for transplant and in pre-sensitized recipients. So thank you very much. Thanks a lot.
Thank you, Dr. Pameja, for that excellent talk. And because we're getting late, so we thought with the questions can be asked during the tea break sessions.
Very good.
Or we can have one or two questions.
I was about to
We
direct all to you.
No?
So because Minu is sitting there, you are there, so.
One, so one small question. So, what do you recommend dose of rituximab in ACLF3 before transplant?
Very tricky. So obviously it depends on so if I'm going to transplant an ACLF3 for this one ABO incompatible, I'll just go with the standard dose. If the cultures are negative before the transplant, after reperfusion, so I won't give it before the transplant. I'll just do the implant, and after reperfusion, like when we're going to give the steroid, at the same time I'll just give the rituximab. So we've done this. I'll just say once, but it has worked for us. And that patient did had a stormy time after the transplant, but he survived. This was in ACLF HBV reactivation. Rakhi will remember that patient as well. So he had 3 or more organ failures, was on ventilator. There was no other donor, and then the wife was the only donor, and they wanted it, so we did it. The titers were very low before the transplant, so that. So
Dr. Gupta, please.
Yeah, one comment. If a patient is not accompanied by his wife, please do not see him. He will not go to transplantation. But the more important question is, how many emergency cases have you done? Because we've not had good experience for emergency ABOI, and you people have a lot of sick patients.
yeah. So in terms of, I wouldn't say the numbers are great, but one ACLF I said, and then we've done pediatric ALF. I think we've done 3 of pediatric ALFs, which are very good to do, and especially if it is less than 5 years old, because what has become a routine now is most of the ALF they comes in, they get plasmapheresis. This has become routine, I think, in most ICUs. In our center, it is like sort of that situation. They will get plasmapheresis. Rakhi is sitting here, so she can. So then once they get the plasmapheresis, then relatives get time to decide they want transplant, don't want transplant. Then the donors will come after 2-3 days. That's a typical situation happen. And then you do the titer, and then if they are low enough, good enough to go in. So if they are less than 32, you can actually think of doing transplant in those situations. So again, it depends on other factors, how the patient is holding on, hemodynamic stability, cerebral edema.
It's not, I said in my presentation that if you have 2 weeks time, then it's different. But say you have to do an emergency transplant.
That's a very tough situation.
It's a tough.
What are the results in that? Because I find very poor.
So we see a lot of post.
So I think we got, I think, so 1 adult, 3 pediatric, and 1 was 18-year-old who actually didn't make it. So we've done 5 of this, and that 18-year-old didn't make it actually.
We have a lecture today in the
On
afternoon
this,
on this. So I think let's discuss that.
Okay.
Thank you so much, sir, for the discussion.
you.
Sorry, as we are running late, please take a quick tea or coffee break, and please come back for the next sessions. Thank you.